In our webinar today, we're going to dive into the crucial role that trust plays in creating a positive workplace culture. We'll look at factors that are driving the attrition of Black and Brown leaders in academic medicine, and we'll explore actionable strategies for fostering supportive environments where all leaders and clinicians can thrive. We're joined today by Reggie Tucker-Seeley. He's principal and owner of Health Equity Strategies and Solutions, and he's a member of the ABIM Foundation's Board of Trustees. We're also joined by Dr. Maria Belalcazar. She's a tenured associate professor and vice chair for engagement at the Department of Internal Medicine at the University of Texas Medical Branch. And last but not least, Dawn Hawkins Johnson, who will be moderating today's conversation. She's the CEO and founder of DHJ Services. She has over 25 years of experience in healthcare operations, advisory services, and leadership across sectors. Thank you again for joining us for what I know will be a great conversation. And now I'll turn it over to Dawn.
Thank you so much, Jess. And thank you all for finding value in this conversation to join us today. I want to get us started, and I want to talk a little bit about why the three of us are here alongside you on this call today. If I reflect back, I remember sitting in this room of very well-known, well-respected physicians, clinicians, leaders of prominent national organizations, and hearing this young Black woman describe how her C-suite role in an AMC was silently and slowly killing her. Although I'm not a physician and I didn't work in an AMC, I felt like she was on the stage telling my history and my story. I think at least two of us and the individuals supportive of this conversation recognize that this current reflection was not a single incident involving this single woman, but was actually part of a pattern that is very recognizable. And with this conversation, I'd like us to take time to unpack it a little bit. I want to expose it, bring trust into the center of this conversation to figure out and figure out what research is finding, figure out what our experience has shown, and talk about what we might be able to do to prevent further exodus from AMCs for talented Black and Brown leaders that need to sit in the centers of education and clinical excellence to support those coming behind them, to support those in the day-to-day work. So with that, I want to turn it over and ask Reggie. You've worked in the academic space for many years. Can you share with us your background and your why of why you're here today?
Sure. So thank you so much for the invitation to be here. Yeah, Dawn, similar to you, and as I sat at the ABIM Foundation Forum and listened to Dr. Blackstock tell her story, it felt so familiar. My doctoral training was in public health. I served on the faculties at the Dana-Farber Cancer Institute and the Harvard T.H. Chan School of Public Health, and also in the Leonard Davis School of Gerontology at the University of Southern California. My undergraduate training was in accounting. I was a first-generation college student. My last accounting job was as an internal auditor at St. Louis University. I received a master's degree in counseling and family therapy at St. Louis University, and I did my clinical internship at Washington University at the Student Health and Counseling Service there. So I've worked in corporate America, I've worked in academia, I've also worked in nonprofit spaces, and I've been very fortunate to have a very diverse work history. But the unfortunate aspect of most of my work history is that I recall hearing the same stories across fields. The challenges of recruiting and retaining people of color and those from historically excluded groups feeling isolated or being the only one. I'm African American and I'm also a gay man. Those with some institutional power often being allowed to bully those without institutional power. But I think what's most different now, I think especially since 2020, is that we're talking about systemic racism much more explicitly than we have historically. And in those conversations, we're not only looking at the landscape, but at what created that landscape. That is, what are the systems and processes that have sorted the individuals and created the distributions of what we see now in terms of workforce diversity. So I'm eager to share a bit more about my story and to reflect on my experiences in academia that mirror some of the same stories that Dr. Blackstock shared with us.
Wonderful. Thank you for mentioning her name as well. Want to give her credit for actually getting us together to have this conversation. And if you have not read her book, it's a worthwhile read. Maria, what brings you to this conversation? Can you give us a little bit of your why as well?
Yes, thank you, Dawn. So let me start by introducing myself a little bit. I'm a clinician who has been in academic medicine for over 20 years. I've dedicated my career to understanding and improving the care of patients with diabetes and to the training of future physicians and subspecialists. I was born in Colombia and came to the United States in the early 1990s. And although now I'm a tenured associate professor, my career path and family trajectory have not been easy. I had to face limitations on funding eligibility early on in my career due to citizenship requirements, had to take a prolonged leave as a young faculty due to complications of pregnancy. And later, I had to give up my tenure track position to be with my children after my marriage fell apart. I've also been resilient, always a hard worker. I was able to get back to academia and to a research career through an NIH reentry award, but decided to give up the research path and become a full-time clinician when my older son's college expenses became a concern and research funding was uncertain. And I am now functioning primarily as a clinician educator. But how did I get into faculty development? This happened 3 years ago. I had time to stop and reflect on my career progress. Why wasn't I a professor yet, despite years of hard work? I had already been in my rank of associate professor for 7 or 8 years. I had clinical education and research accomplishments. What I discovered was that I didn't have, during all my years as faculty, a career mentor or coach, and that my presence at the national level that was required for me to get promoted wasn't strong enough because it didn't go beyond my papers and my work presentations. I also realized that out of 29 full professors in my department, only 2 were women, non-Hispanic. It was then that I started reading, and I saw that this was actually a national problem. Despite Hispanics and Blacks making up 34% of the US population, we only together make up 7% of full professors across medical schools in the US. And furthermore, as of last year, Black and Hispanic women combined make up only 2.2% of full professors in internal medicine nationally. That's when I decided I wanted to work on this and make a change.
Thank you for that. As both you and Reggie were speaking, I was reflecting back to the mentors that I had along the way. When I was writing I worked for the federal government, spent 14 years between the VA and CMS. And as part of that evaluation process, you have to write about why you should have a promotion. And without my mentors, I wrote this very eloquent little paragraph about what I thought I had accomplished. And my mentors came back and said, Dawn, you're never going to get promoted if you don't write it in terms of what you've done fiscally, what you've done to promote other people, what outcomes you've contributed to, how you've worked with other teams. So along the way, I've had these wonderful, I call them my angels, guiding me along my career pathway to tell me, no, you're not going to ever advance if you keep doing it this way. And as you were speaking, Maria, when you come to the realization that I haven't made it to where I think should be, without those angels and mentors in your life, many of us would continue down the path, very disgruntled, not knowing what you actually had to do to check those boxes that you didn't even know were there. So Reggie, when you think about all the decisions that you've made personally and professionally, leaving some spaces for peace of mind and to survive, what burdens do you feel, if any? Feel like you've
Burdens.
abandoned the next generation? You know, how are you
Yeah.
digesting this?
Yeah, that's a great question. I think when I reflect on my time in academia, I wouldn't do it differently. That is, I would always start there. I think it was a great foundation for the work that I'm doing now. But I think the aspects that can be considered burdens are really more a function of the sort of larger systemic structures. That is, academic medicine, and I was in a school of public health and at a cancer institute. I think it's hard for everyone. But at times you encounter some pretty competitive individuals who feel like if you're winning, whatever that means to you, then they're losing. And so I think I've really tried to approach my career from a standpoint, after I've tried my best, what is meant for me, I will get, and what is not meant for me, I won't. And so sort of navigating those spaces, I think has been, and having the mentors to help me navigate, those interactions has been helpful. But I think another burden is really isolation. That is, being the only one. So insert whatever demographic group you're a part of. But if there are a few of you, then getting confused with that other person often makes you feel like you aren't really being seen. And so, but I think sort of leaning into, those burdensome experiences, but having that mentor team around you to sort of help you manage those burdens, I think is critical. And then thinking about not only the people that help you, but thinking of them as a team. I think that has been, I guess, over the last 10 to 20 years, this notion that not one person is going to be your mentor, that you're going to have to surround yourself with a team of people to sort of help you. So for example, there are mentors that will help you, sort of navigate, the landscape of the institution. But as Maria mentioned, you may also need a different mentor to help you navigate, what does it mean to be a national leader in a particular area? So that might be a completely different mentor. And so figuring out how to put those people together to help you manage those particular burdens is really crucial.
I love that you said that isolation was also a burden. I remember I was with a new team. I had just been hired into an organization, and one of their colleagues from a competing organization walked up to me and was so excited. And she said, "Where did they find you?" And I thought to myself, I was never lost,
Yes.
but
Yes.
I'm not the only. But in that moment, I felt very much like the only. So Maria, I know you have this wonderful faculty advancement program. Can you tell us about it? Because I think, as Reggie said, the team that you need to help move you through and keep you there is critical.
Yeah, so our program, it's called the Leap to Action, and it's funded in part by the ABIM Foundation. It was designed to come up with strategies to support the career advancement in faculty that are experiencing or at risk of career delays. So we decided to focus on early and mid-career faculty who had remained within their academic rank for 5 or more years. And the first step was to ask them to take a pause and reflect on their career progress. So what we did is we developed this tool, the Leap to Action survey, that actually created a hard stop for them. They had to stop and reflect on their career journey. Clinicians are very busy. They're, may be drawing satisfaction from working with patients and trainees and don't stop to think about their promotion process. So we asked them to think about and rate their self-efficacy relating to career goals and planning, scholarship development, skills relating to leadership and networking, and also to assess and rate their barriers to career advancement, just like lack of mentorship or institutional support, lack of purpose, challenges in the balance of work and personal life. And we actually had a high participation rate, over a 75% response rate to our survey. Most of the faculty felt that their careers were not on track. They were not very confident about developing their career professional goals. Half had never had a mentor. 78% reported difficulty overcoming professional challenges in that balance of work and personal life. Unexpectedly, though, of this group of faculty, they didn't differ in terms of gender or race ethnicity from the remaining group of our early and mid-career faculty. And what was very concerning were some of the comments that appeared to show discouragement and lack of engagement. So we decided to dig in deeper, queried all the faculty in the Department of Medicine to kind of have a better understanding of what was going on. Our department had not completed a survey like this as far back as I could remember. And what we discovered was eye-opening. Responses relating to trust and equity and items on opportunity and belonging received the lowest scores. So things like, at work, my opinion matters, or I'm valued as an individual at my institution, or I'm confident that my accomplishments are compensated similarly to others who have achieved their goals. But again, this shouldn't have been a surprise because it's a national problem. There's this survey that the AAMC puts out with 17,000 faculty respondents across all medical schools in the US. And it also showed the lowest scores on faculty input on decisions, transparency about compensation, and faculty wellness. So our program took this problem of faculty engagement and belonging as a priority. We presented and shared the data with all department faculty, invited everyone with an interest to join and be part of a work group based on their interests. We actually met in the spring, and the groups shared ideas and concerns relating to compensation, mentoring, and well-being. The other thing that we've done in the program is create a faculty promotion grid. And I just submitted it to the Office of Faculty Affairs for their review. What this grid does is it serves as a guide for individual faculty to identify the specific activities that they should be looking at to become eligible for promotion according to their rank and mission. But very importantly, the grid is also serving a purpose as a tool to introduce transparency and equity in the promotion process. So if it does get approved, it would support the application of consistent promotion criteria across faculty, departments, and schools. And finally, going back to the mentorship part, we're developing this virtual scholarship and engagement hub where we're having peer mentors group around shared interest on scholarly products.
Wonderful. And as you were talking, I kept turning my mic on, turning it off, because you were saying so many wonderful things that I didn't want to lose. And I want to go back because you talked about the survey that you pushed out. And in that survey, if you've ever taken a workplace survey before, there's an element of trust there, because somewhere in that survey are identifiers. And when you serve in the C-suite, or if you're a senior leader and you identify your race, you identify how your gender, you identify all those things, and you say you're disgruntled, you say you don't have this, there's a lot of trust that has to happen in putting those identifiers out, because it's really then easy for the organization to go back and say, oh, looks like Dawn's unhappy. Looks like Reggie's unhappy. And so I want to talk a little bit about that, because Reggie, as you made decisions to leave leadership, and you made decisions, and I've made decisions to leave organizations, what was it that made you leave? And what was it that could help the leaders of these systems and organizations retain their Black and Brown, very talented core of individuals? And if you could tie it to kind of what Maria was saying in her advancement program, I think a lot of the nuggets are there, but I'd love to unpack, because you and I and Uche are not single. This is not just a 1, 2, or 3 thing. It's happening across the country. that's the reason for this conversation, but I'd love to start there.
Yes, yes. And I think, as many folks are leaving and as institutions are attempting to address some of the issues related to diversity, equity, and inclusion within, academic spaces, we've created over the, I guess over the last 5 or 6 years, we've created these new roles of, chief diversity, equity, and inclusion officers, or sort of chief health equity officers, and these people, might be responsible for both of those roles. And I think what's really important sort of in that regard is sort of recognizing that those are distinct skill sets, that someone who is leading sort of diversity, equity, and inclusion is going to have knowledge related to, employment related policies, but also skills and knowledge related to organizational change and organizational culture. And it's important that those additional competencies, other than just group membership in a historically marginalized group, is the reason that someone is put into those roles. So some of the reasons that that I left, sort of my reasoning came about during the COVID pandemic. As discussions were being had in the country around disparities, I felt like those of us who had trained in this work, who had done research in this space, fewer of us were at the table talking about what we know about health disparities. And I wanted to get closer to doing that work. So I took a leave of absence to work for a prostate cancer education support and advocacy organization as their first vice president of health equity. And in that role, I realized, the conversations that we had been having for decades were brand new out in some communities. And so I decided to, go full in to do this work and to share what I knew. But I think some of the reasons that people decide to leave and some of the reasons that I chose to leave is you feel like you can have a greater impact outside. You feel like you can make a bigger difference when you're outside of the academy. Some people go to private industry, some people go to government, some people like myself, you create your own thing. And so for me, it was the desire to create my own thing and to realize that I could have or could make a greater impact outside.
I love that, because what I love about you, Reggie, is that you are always on the positive end. And I'm going to take us to that place that we never want to talk about. And it's the other side of, I had to leave to save my life, which is what Dr.
And so I do have a story that I would like to share, and but it is positive, because I was trying to think of a story to share, and it has a positive ending. But I was at an ABIM Foundation related event, and I was called the name of another Black colleague. And but the colleague realized it almost immediately their mistake, and they recognized what happened, and they apologized. Now this has happened to me so often that I have a usual script, and I didn't realize I had a usual script until it just felt so natural sort of coming up, the words of saying, oh, that's okay. I just want to get past this situation really quickly. However, this person asked to discuss it, and that had never happened to me before. This person acknowledged what had happened, how that must have made me feel, and they apologized for it. And it wasn't one of those apologies that usually is so bland and has this undertone of get over it, and I'm sorry you didn't understand my intention, which was not to offend. No, this was a genuine apology, and it wasn't focused on intention, but on impact. And I tell this story to highlight that trust is not just about, whether or not one intends to be harmful, but it is the outcome and whether or not someone is actually hurt. And that situation made me trust that person at a much deeper level. Now, I share that story because in academia, I've been called every other Black person's name in my institution. No one ever apologized that way to me before.
I thank you again. And I want to just put in the conversation 2 comments that were put in the chat. And the comment is, there are so few of us as Black women in academia that what we say in so-called confidential surveys is never truly kept confidential. We can be easily identified, repercussions often follow. And I think, I'm working on something with another researcher on prefer not to identify for this very reason. You're not.
I think that's
Yes, Maria.
I think that is sad. And for example, our survey was the responses were confidential. And I make sure, and that this is probably why I've had a high response and I'm trusted by my peers, is I don't share that kind of data. Even if I could guess, I'm not going to share. I make it a generalized statement and I put my life in front of it. But I hear what our participant was saying.
And I think that's where we get into trust. There's also another comment about the reason why you leave is because you feel like you have no impact, and that's extremely demoralizing. And so to see your work not go anywhere or not get recognized or be underfunded for this wonderful position that you thought you had that was sorely under-resourced is why some people also leave. I
wanted to interrupt, Dawn. So if you look at the AAMC survey again, so this is 17,000 faculty across the country. They looked at why people had intention to leave, and it was 25%, by the way, of faculty are thinking of leaving in a year or two, and it's higher in some other institutions. But for underrepresented minorities, compensation was at the top. And for women, it was work-life balance. So workplace climate was there on the top 4, especially for minorities and women.
And not to go on the compensation tangent, but again, it's part of that package. If you don't know what you should ask for, if you don't know the rules of compensation, you will sorely undervalue yourself, and no one will say, no, we should pay you more. And so I think I learned that a long time in my career by a coworker who was boasting about how much he made from me being his subject matter expert. And I said, oh, really? Tell me more. And he was telling me about his salary. And I turned around and went back to my leadership and said, if I'm the SME and my salesperson is making this because I'm with him, we probably need to reconfigure my compensation. And so unless you have that information, those resources, that team of supporters around you, you are navigating, you're playing a totally different game. I want to get to the question. There's a question in the chat, and I'm going to tie it to something that we plan to talk about. So academic medicine involves complex relationships with the community, with leaders, with clinicians, and it's often complicated by racism, barriers, and unfulfilled resources. What does trust and trustworthiness look like in these relationships? And how does lack of mentorship affect how faculty from underrepresented groups navigate those aspects of academic medicine, community leaders and clinicians, but also student disrespect?
Wow.
Maria, I'll let you tackle that one first, and I'm happy to go second.
Sure. So I believe that trust is fundamental to the practice of medicine. How can doctors in academic institutions expect their patients and communities to follow recommendations if they haven't earned their trust? Why would they admit to us, for example, that they're using their relatives' insulin or skipping insulin doses if when we ask them, we're not trustworthy? Or why would people agree to get vaccinated if there's no one in the healthcare system who they trust that they can reach out if they have any fear or concern? And then why would faculty not think of leaving their institution if they feel that they're not being heard? So I think trust is very important. We have to learn to listen with humility, and we have to, show evidence, not just talk, but evidence of genuine interest and care so that this culture of trust can develop. Disrespect from students. So I am one of the hats I wear is that of a clerkship director. So I direct the course of internal medicine for the medical students. Our school is quite diverse. And what we focus on, or the way we address these things, is we do a lot of reflection with students. We have these practice of medicine sort of small groups where we discuss these sorts of issues. Occasionally they come up. I don't think I've had, most of them that we've learned about is in the wards. So a student may share that they thought their resident was not respectful or things of that sort. And I think, again, it's putting it out there and supporting the students and stopping these issues when they happen.
One of the things we talk about in public health is, why do we see disparities across, and similar disparities across multiple conditions? And there's a theory called fundamental causes that suggests that the reason that we see these differences across multiple conditions is because of things like money, power, beneficial social connections, sort of all of the things that give us, sort of the tools to navigate our health and our health care. And I think we are really great at sort of taking our research tools and sort of focusing out on the community, but we rarely sort of take those same tools to focus inward, because I think we could attribute those same things to the reasons that many of us sort of have struggled with navigating these spaces. And that is because of money, power, beneficial social connections, and many of us, really just not knowing how to navigate those spaces well. And so having those resources and sort of recognizing that those are necessary. I think the other issue that has come up is this difference between how we define equality and equity. So equality is giving everyone the same thing. And equity is giving people what they need when they need it, or giving patients what they need when they need it. And so for historically excluded or minoritized individuals navigating academic spaces, giving them what they need when they need it is an important and critical tool to helping them navigate this space.
Thank you for that. And our chat is active. And so I want to just acknowledge a couple things in the chat. First, we want to make sure that we bring up that faculty from different national origins, in particular, those with very strong accents, face similar struggles. And the need of this group is often disregarded. I want to touch on that. And then I also want to touch on that someone put in there, the student voice depends on trust to speak up. And I want to tie it to an article I read by a young resident that was doing a psych rotation, and the patient called another patient something that was very racially motivated. And no one from the clinical team said anything. In fact, when she went back to the clinical leader said, oh, that's just her diagnosis. But as a member of that, of someone who's been called that term, she was deeply offended. And it impacted how she then saw that clinical leader and eroded the trust and the other patients as well. So I want to just touch on, if we could talk about the populations of individuals, of faculty that are from different origins, that have strong accents, that face the same struggles. Like, what does this look like? Trust and mentorship and support look like? And then how do we make sure that the students that have invested so much time in becoming physicians and becoming part of academia find a place to share what they're experiencing? So the exodus does not continue. I think the focus of this is to figure out how do we address the exodus?
Maria,
I think we need to have these conversations at the places where they're happening and in real time. I think leaving them out of academia is not right, because as you point out, Dawn, they are happening, within the academic institutions. I've seen it. I've seen, for example, some patients not wanting to be treated by a physician because they have an accent or they're wearing a certain garment. So I think, and in that situation, it is important that the faculty has someone to reach out to, because, and that they know how to respond to those situations that really reflect a total lack of respect. And this is very important for our students, because if we let that happen, how are they going to learn? How are they going to be professional?
I want to just add something before you respond, Reggie, because I think I misunderstood the question in the chat. And the question was, students disrespecting a faculty member that is Black, brown. How do we manage that when you don't have another faculty member with similar ethnic and racial background to work with, to confide in, to problem solve with? So this is that isolation part.
Yes. So I think if our listeners haven't read Legacy by Dr. Uche Blackstock, I highly recommend it, because she provides so many examples of disrespect from patients, the code switching that she has to do, the implicit and explicit bias from patients and colleagues, and having to serve as a safe space for those coming behind you, having to navigate this environment. And so I think what's most important in these environments is that the people who are often on the receiving end of those offenses are not the only ones speaking up. This has to be an environment that is created where everyone feels that they can speak up, which means that it has to come from the top. So I do a lot of work in the health equity space, and I often say that health equity is a value, a process, and an outcome, but that value has to be communicated from the top. So that is, senior leadership has to be on board for communicating that value so that it makes it through the rest of the organization. And so it is important that the ones who are often on the offending end of these of this disrespect are not the only ones speaking up. So that means that our white colleagues are going to have to be very loud voices in these spaces to disrupt this kind of disrespect that we're discussing.
And the student involved in that situation would probably need to have a discussion about the underpinnings of what occurred, because they need to learn, and in some way they also need to be held accountable.
I want you all to, I'm going to read this as part of the chat, and then I think, we could have a quick set of comments about it, and then we'll eventually go to Q&A. So there's a common practice where trainees are treated poorly by patients, and bystander faculty members do not, quote, stand up, end quote, for their trainees. It's critically important that faculty stand up professionally, call out the bad behavior. And so I think we have to, if it's not directed at you, if you are not part of the minoritized, disenfranchised, Black, brown, have a different dialect, have a different, if you're not that and you still witness it, it's still on you to say something. to address the behavior. So I don't want the additional burden to sit on our backs, additional burden, because there's additional burden that then is that my job I have to take up for everyone. No, it's our collective responsibility. So I want to make sure that this is part of the trust conversation. Do I trust my colleague? Do I trust my organization? Do I know that there is someone there, because I am the only, that will also stand beside me? So I want us to just look at, how do you, as you think about and reflect, how pervasive is the theme of trust in your experience and your emotions around this issue?
I've discovered through the work of others and my own that trust is key for academic medicine to succeed in its mission of improving the health of our communities, and for our physician educators and researchers to feel engaged and invested in their mission. I found out that, the lack of promotion is not just a lack of publications. It's a problem that has underlying structural factors, and that we need to address trust and create trust for things to change.
And creating trustworthy institutions. And being a trustworthy institution means being attuned to the organizational culture, and whether the organizational culture is welcoming in general to people of color and to women and to all of the groups that we're describing here that are, again, on the receiving end of this disrespect from patients and potentially from students and from others. And that this is coming from the top, and that it's not going to happen overnight. So similar to the work that we do in health equity, where we are, giving folks sort of hiring these chief health equity officers and giving them, assuming that they're going to eliminate health disparities within a year or so. Sort of organizational change, and organizational change takes time. I mean, I remember when I was working as an internal auditor, sort of one of the things that my director said back then was, getting higher education to change is like pushing an elephant upstairs. And every time we would go into a department to try to do an audit, to try to get them to change, it was like pulling teeth. And so I think recognizing that, change takes time, but that we have to be committed to that change. Just because something is hard doesn't mean that it's not something that we're going to try to do.
So I want to give us some, and I love the chat, and I will loop you into the chat, but I want to make sure that we are identifying, what organizations can do. So what changes at the leadership level could help retain Black, brown, and diverse leaders?
So for one thing, supporting the career advancement of the people that need the help. It shouldn't be just focused on the early faculty. It has to be addressing everyone that needs it. We need recognition awards. We need people from minority backgrounds, women that don't get to those leadership positions, to be offered positions of leadership, to be parts of committees. We also need to modify the time that clinicians and clinician educators have so that they can be involved in these career advancement activities. Make the compensation plan, the promotion process equitable and transparent. Those are things that I think the academic institution can do. But I also think that there are things beyond the institution that need to happen for major change to occur. And like Reggie said, this is not going to happen overnight. But making sure that children from marginalized areas in the city get to go to school, that students in community colleges see opportunity to, if they so desire, to go into medical school. Because we can't start doing the work only at the level of faculty. We have to go way back.
Agreed. And I think, we've set up so many pipeline programs. I myself have participated in multiple pipeline programs, but this pipeline is leaky and people drop out of it. And I'm loving this conversation around trust and trustworthiness. And I think that's something that the foundation has been a key leader in making that distinction, because trust is important here, but it's also whether or not your organization is trustworthy. And how trustworthy is your organization in handling your most vulnerable staff members? And one thing that I remember when I was a junior faculty member, I had a network of peers, and we often discussed bullying by senior folks in the field. And I think an organization has to ask itself, are there repercussions for staff members who might be respected in the field, but bullies to their colleagues? And how does your organization protect those who need the most? I think asking yourself those questions, I think, are critical.
I have so much to unpack there, Reggie, but I'm just going to move on, because I do think there is an aspect of, if you don't have a mentor yet you have a bully, what's happening in your organization.
Mm-hmm.
And one of the questions in the chat is a challenge that they're facing around the hidden curriculum in academia. So there is this hidden curriculum that's the unspoken rules of academia. And I know we're getting short on time, but if you have any thoughts on how can institutions make their hidden curricula more transparent?
So I can talk about the promotion process, for example. I feel that if people get promoted, if there's not a clear guidance of how they may get promoted, there's space for hidden curriculum, like the participant was saying. I think we need to have everything out there. So, and I really want to share that, for example, in our institution now, we're making major changes in the promotion process, and all those changes were shared with all the faculty. So everybody could speak up and say what they felt. And then there was a final document that was finally put in place. So that's a way of increasing transparency, giving everyone a voice.
I think too, saying it out loud. I remember when I started in public health, we could not use the term racism. But now we do. Now we use the term explicitly. And so I think conversations like this that raise awareness around the issues and that shine a light on the hidden are critical to seeing an improvement in this space. And again, the organization from the top has to be committed to making the hidden not hidden, to making the invisible visible. Because if they are not, then it will continue to be hidden. And I mean, we can say that we want change. I think in many of these conversations, it's like, people say that they want change, but they don't want to do anything differently. Change comes from doing things differently. So things are gonna have to be done differently, and those things that are hidden are gonna have to be unhidden and made visible for everyone.
I love that. And I do think it is, we have to say it out loud, and we have to be radical and dismantle it.
And not just the people who are most impacted are saying it out loud. Again, it has to be the people that come to the table with the most privilege also being very vocal about these things that are hidden and unsaid.
And I love that in the chat, Maria, when you said recognition, we need recognition. I don't need a pat on the back because I'm a hero. I need recognition. And I think this conversation, and as we talk about racism, trust building, hidden curricula, how to navigate, the burden of leaving, the burden of staying, what it does to you as an individual and the responsibility you feel by staying. We have to talk about these things more in our organizations, in our small groups, with one another. I think holding it close doesn't do all of us any good. And I'm so thankful for Jessica and ABIMF for allowing us this space to have this very public conversation about the things that are impacting us and us, the royal us, the healthcare system. Because as your leaders that represent a fair amount of the population leave, we're still missing the voice at the table. And so I really want to just take a moment and thank you, Reggie, for being very vulnerable and sharing your experience, and Maria being very vulnerable and sharing your experience and your program. And I want to just thank those that have participated in the chat. There's a lot of folks that are glad to be invited to the table, who still are waiting for the invitation to be at the table, who need someone to help them understand what to do when at the table. And I think that's part of the hidden curriculum. If we don't share with each other, if we hold it close, we're missing the opportunity to see one another grow and accept the challenge that we have in front of us. I want to just open the floor to the two of you to share, as you just reflect on this conversation, reflect on your experience in academia, your experience in healthcare, share any parting thoughts.
Share any current thoughts, you said?
Yes, I'll start, and I will say that oftentimes in my consulting work, I sit back and I say, will they handle it if I say it out loud and call it racism? And am I doing them a disservice by not calling it what it is? And is there a way for us to move forward, acknowledge the harm, address the harm, and build infrastructure so that we don't repeat the harm? And so I'm going to ask Reggie and Maria to just share, based on your experience, based on the work that you're doing, what would you share with this audience?
I think speaking up out loud and knowing that even though you may feel alone, you are not. You are not. It's like when I started reading and saying, well, this is not just happening to me. It's happening, across the institution. It's happening nationally. So that's one thing that gives you power. And the other thing is creating groups and peer support. I think it is important because there are many resources that you don't know about. I remember, for example, I was a young faculty and I had an issue with one of my supervisors. I didn't know. I went and I talked to somebody else. I didn't know there was somebody at the institution that's called an ombudsman. So somebody that acts like sort of they listen to you and they try to solve the conflict, and that would come in place when there's a leadership person. So somebody that's in a position of power is doing something that you don't feel is right.
Yeah, I think, in my own work, I often ask, what does an equitable healthcare delivery system look like as we're starting to amplify health equity? So I think in this conversation, asking, what does an equitable academic workplace look like? And so it goes back to our difference between equity and equality. We don't need to give everyone the same thing because they don't need the same thing. We need to give people what they need when they need it. And for those without the beneficial social connections or the familiarity with academic work environments, this might mean providing support in terms of networking and mentoring with other faculty at the same level and at various levels, and mentoring teams to guide folks in terms of all the aspects of what it takes to be successful in that environment. We know that research in healthcare delivery has shown us that navigators are helpful. Perhaps having an academic career navigator or a coach to help people navigate through that environment is what would be helpful here. So that's at the individual level. At the systems level, again, we've talked about it here already, that sort of from the top, sort of valuing, sort of making the invisible visible, and ensuring that, again, that people have what they need when they need it, and that you aren't just checking boxes in this sort of topic of diversity, equity, and inclusion, that you are really committed to ensuring that you have a diverse workforce that feels supported in their implementation of their various roles.
Well, thank you, Maria. Thank you, Reggie. So much more we could unpack, but I think we're almost out of time. So I'm going to turn it back over to Jess.
Yeah, thank you. Thank you for that. And thank you all for joining us today. Dawn, Reggie, and Maria, this was an insightful and meaningful conversation. I don't think I've ever seen the chat this engaged, and clearly there's more to talk about here. So I think we should dive back into this conversation.